Yeah, thank you everybody, and thanks in particular to Claudio and Aina to put up this nice symposium. I'm a clinician. I'm happy to address our needs and concerns regarding the guidelines, and I think I hope I can make it clear that we really need more common action. Now, first of all, these are my conflict of interests, and second, another conflict of interest. I'm not member of the ILAE. In contrast, what you think from the title, I'm just a member of the Swiss League of Epilepsy. However, I'm currently supervising a white paper or a recommendation of a joint effort of the ILAE, IFCN for the yield of EEG in a first seizure. You see how basic our level is. What is the ILAE? It was founded in 1909, so we have around anniversary of 110 years. You think you should be much more advanced, but this is really around the world. So let's say not everybody is in a developed country, and therefore the objectives are relatively basic: to advance, disseminate knowledge about epilepsy, promote research and training, and improve services and care for patients. So our initiative here, or what was launched by Claudia and Aina and others, that refers to the third point. There are currently 129 guidelines and reports, and they can be grossly categorized in these five classes. So definition of epilepsy, different type, epilepsy management of unprovoked seizures and adult techniques. So everything around EEG would belong to that, and of course treatment guidelines. These are a lot of reports, but at the end it boils down to 5 guidelines on EEG. So nothing on MEG, but just EEG. And here we have only one, which is probably interesting to us. And then this is SCORE, which is sort of a standardized method of reporting EEG. So nothing really fancy. This is sort of a white paper just by, it's not ILAE, but IFCN, also International Federation of Electrophysiology, and they discuss here the clinical utility of EEG in diagnosing and monitoring patients, in epilepsy patients. Why always epilepsy? Because this is if you want, these are the first clinical clients on anything on EEG and source loss localization. And it serves as an excellent model to verify if the hypothesis and models are right. So some of the patients are operated, and if the source is identified correctly, the area of resection, then obviously whatever you calculated was right. It's a little bit more difficult with this, with the connectivities. So in this paper, no mention of minimal electrode count, which came in another paper. Claudio referred to that, and that is, I'm almost embarrassed. It's so basic, saying that the 19 electrodes or 21 electrodes are no more, shouldn't be the standard. It's just not enough. Honestly, my personal point of view, even the new standard of 25 electrodes has to be changed in your slide. The new standard of 25 electrodes is not even, not really enough. You can see here the projected on a brain, and you see also that the basic temporal lobe is not covered. Why is it important? Now, if you investigate epilepsy, 2/3 arise from that area, or dementia or other topics are often involved in this region, and that is, with the current standard, not really sampled. But there are also other other areas here, the frontal lobe, parietal lobe, there's only one contact. So if you think of that to the very end, you know that even not 25 is enough, and we should work all together to get a higher standard, let's say around 30 and 40. That's my personal guess. But you cannot just decide that, but you need to CE mark. You have CE marked cabs, you have to have machines, you have to train technicians and tell them this is a new standard, you have to work a little bit longer or see less patients and so on. It's not so easy. This is a new standard. You can see here how this is covered better the inferior and indirectly also the mesial aspects of the temporal lobe. Now, the history of EEG, MEG, I don't think I tell you something new, that the EEG was developed before the MEG, but both were about the same time coming up with a high density tool. This first clinical report I found in '98, and here the first system sold with 122 squids was in 98, 92. So I don't know which the clinical report with that, but I would say in the moment it was on the market, it was used, and now since more than 20 years, we have the opportunity to do high density recordings. It did not become part of the clinical routine, and that's actually quite sad. Now, the publications rise, although per year 25 to 30, that's not that high as MRI or functional MRI. And the reason is why I think it never made it into clinics is that there are initially the controversy, which is better, EEG, MEG, didn't help, neither of them. Controversies about the best localization method. You have these talks about, is it this way, distributed, dipole, which kind of linear, non-linear tool. Now this is shied them away, the clinicians, and also at the end how many electrodes are really needed. That's more for the EEG. Now if you look into how many prospective studies there are that for MEG and EEG, that's not a lot. Prospective study is a holy grail in clinics. So you can start working or using a method, and then you see how it changes your decision or how it improves outcome, and that's much more valuable than the retrospective studies. Now the first one is in both categories, and the rest is a little bit more in the MEG and EEG, but as you can see, this is not a huge extensive list. Now, not the ILAE, but 25 centers would call themselves Epilepsy, set together. We're a consortium which is supported by the European community, and the overall goal is to improve awareness and access to epilepsy surgery. So it was launched in 2014, and these 25 centers, the biggest centers in each country, they meet and discuss different things, and among them was electromagnetic source localization. So the first thing what we did is just to look among us who does what. And one center couldn't respond, so it's left with 24 centers. And what you can see here is that with the MRI, most centers comply with the recommendations. The special sequences you should do not to miss epileptogenic lesions. Sadly, not all of us, but 22 out of 24 using coronal flare. That's a quite nice sequence. That's pretty good. Most of the centers did children and adults, so it gives you, let's say, a nice overview of pediatric and adult neurology. When it comes, if we look at the PET, positron emission tomography and Ichthyos spectral nuclear imaging exams, situation is not so bad. So 92 have access or in the house or outside, but they can send a patient, and a little bit less in Ichthyos spec because it requires an injection during a seizure, and you need people who are trained and sit next to the patient and do that. So obviously not everybody has these resources, so that's why it is a little bit less. And then the analysis visually or post-processing or SPM, there's not much discussion about it, as like also with the MRI processing. Now it comes to electromagnetic source localization, and I would say here in Europe we are a little bit more advanced than elsewhere because a lot of centers do it. There's a much more, let's say, history of neurophysiology. However, only 12 centers use it. MEG alone in 3, only EEG 5, and 4 centers do both. Now, when they looked into what kind of algorithm is used, so yeah, most often it's an individual-based model. So you take the patient's MRI and co-register with the source, and the source is identified either with dipole or distributed source model. There's no real information on the specific indications. Nobody knows. Like in Geneva, we do everybody, and then other places, only if I'm not sure or something like that. When you take only EEG, because EEG is really the tool everybody has at disposition, it's only 37% of all centers. That's not a lot. And then they looked at how many, what kind of tools are there. You can see pretty much every center does a different source localization. It's a little bit better for MEG because it comes with the dipole program, and that leaves the clinicians not much choice. So that's a slight difference. But this is pretty much a lot of noise and shies away clinicians because you never know if it's the right one or the bad one, although probably at the end it's not so much of a difference. We created also a smaller consortium between the Austrian, German, and Swiss new epilepsy groups. It's outside ILAE, outside IFNCN, and to define really what are the requirements, the basic requirements to run an epilepsy center. Sounds simple to you, it isn't, because a lot of politics is in there, and of course at the end money and reimbursement issues. So in our consortium we decided a couple other things, but the technical minimum equipment is a video EEG and an MRI, and also the possibility to have more than 64-channel EEG, and at least two of these methods, and that includes EEG and MEG. So I'm pretty proud that we got that, and this is an imaging tool like a PET or the SPECT. We also, our epilepsy consortium, European level, we looked into what is the evidence right now that this is moving us forward. And we reviewed the literature altogether and excluded the papers with less of 10 participants, not enough follow-up, and those who don't provide data, who is seizure-free and who is not. So these are the big categories, and then you have to chart that and be able to review that and calculate, do a meta-analysis. So, and also studies which use less than 64 channels. These are the results. First of all, a lot of studies had to be excluded. Also on different issues, the population was not interesting, not for this purpose, and no reference standards, and so on. The reference standards is seizure-free after operation. And then at the end, we had only 11 studies, so 8 MSI, MEG, and then 3 based on high-density EEG. And these are the results, and these are actually very good for source localization. So high-density EEG and source localization, the odds ratio is almost 10. So that means the chance to become seizure-free is 10 times higher if you consider the localization of the source and take it out. 4.7 if it's the MEG. MEG also introduced a category of partially concordant, so some of the dipoles are inside, outside, still 1.7. So most of the clinical tests have not 10 at odds ratio or 5. So here we have an excellent tool which is not really exploited, and for the reasons I just mentioned. So I hope I could convince you to pursue the research and maybe extend that to other questions than just source localization. It is extremely useful, and though the few studies which have been done prospectively also, they found an extremely high odds ratio for surgical success. It did not, unfortunately, become a part of the clinical routine, and this after 20 years. That's a problem. The MRI people were much faster, the PET people were faster. So I guess it's, we all think this is a little bit of a nerdish tool, and everybody has to have somebody who knows to do that, and there's nothing inbuilt in machines. There's no real basic knowledge and no simple procedure for clinicians to use that. So at the end, I think we need more clinical studies with also in other fields of epilepsy and with relevant fields, relevant question, multi-center, more prospective studies. We need more closer collaboration with clinical and fundamental research groups, but not like comparing 15 different algorithms, but clear-cut questions, and then also studies with larger and more publications also in general neurology journals, not only in the niche journals. So at the end, they look also a little bit mature. Thank you for your attention. And those who never been in Geneva, next year there's a possibility for the Epilepsy Congress. And those who want to work on this issue in Geneva, give me a contact. And then I was asked to put up this slide, which I do. And thank you for your attention.